Dear student, here's the video as you had asked about minimal intervention dentistry. Now, when you're writing an answer for a long question for minimal intervention dentistry, these are the topics under which you can elaborate the answer. This can be asked as a short note as well as a long question. Remember, definition is very important. So you can write the definition given by Tias et al. As a philosophy of professional care concerned with first occurrence, early detection, and earliest possible cure of disease on a micro level, followed by minimally invasive treatment in order to repair irreversible damages caused by such disease. So, what does the concept of minimal intervention dentistry involve? The main goal is to conserve healthy tooth structure. And the main focus on minimal intervention dentistry is to prevent occurrence of new lesions, and whatever lesions are there, if they are not cavitated, to remineralize it. And even if there are existing cavitated lesions, it should have a minimal dentist intervention. So the amount of tooth structure which needs to be removed should be minimal, and the restoration is preferred with an adhesive material such as GIC along with its modifications such as resin modified GIC. And now the focus is on using composite resin restorations. One important concept which minimal intervention moved towards was from extension for prevention, which was done earlier to prevent further occurrence of caries. Now the concept of minimal intervention dentistry is prevention of extension. So if there is a small lesion, only that is treated, and if there is potential for development of further lesion, it is prevented from occurring by preventive strategies, and there is no extension of the cavity preparation. So there are four main approaches to managing caries here. You are detecting, diagnosing, caries on a microscopic level. Okay, this is mainly the diagnosis part. And if there is just incipient lesion, you have first approaches non-surgical modalities, or if you're using a surgical, that is cavity preparation, you use a minimal surgical intervention. And the main aim is whatever is remaining tooth structure, that should be preserved. And apart from that, any tissue which has a potential to remineralize, that is also preserved and not removed. And the restorative materials which are used are the adhesive biomaterials. Okay. So first, as you can see, we identify, prevent, and treat and control further caries occurrence. So under this concept, there are different headings. In a short note, you can write this and just write 2 or 3 lines about this. Now, each of these topics can be come as a short note separately also. So I'll be addressing each and every topic in the upcoming slides. So the first is early diagnosis of caries. Okay. So here there is early detection of carious lesions. And now visual, tactile, and dental radiographs are the commonly used methods. And it also involves in a patient whom you suspect, you can monitor their caries activity. And this has to be done on the appointment as well as over time. Okay, so you have learned about swab test, Snyder test, Alban's test. This can be mentioned. Now, if you want to detect caries in the earlier stages, in that case, there are newer advances such as optical coherence tomography, QLF or quantitative light induced fluorescence, and fiber optic transillumination, which are helpful in early caries detection. Apart from that, the classification of caries has moved on to a method where you can quantify the caries. So if it is an early caries, then the approach for treatment of that caries will be changed. One of these methods is Mount and Hume's classification, which was given in 1997. And now you have ICDAS classification also. So Mount and Hume classification classifies caries based on location and size. So the location are three. That is pit and fissures, contact area between two teeth, and cervical area in contact with gingival tissue. Now, the size classification is from 0 to 4. So, early carious lesions are in size 0 and size 1. So, size 0 is a small lesion without cavitation which can be remineralized, and size 1 is a small cavitation just beyond healing through remineralization, which may be remineralized or which may have a very small cavity prepared. Size 2 is a moderate cavity, size 3 is an enlarged cavity, and size 4 is an extensive cavity, all which require surgical intervention through preparation of cavity and restoration. So when you are writing about Mountain Hume's classification, this is a graphical representation. The first number represents the site and the second number represents the size. So if you have 1.0, it means that 1 is the pit and fissure and 0 is a no cavity or just the start of a cavity. And this is how you should represent it in your answer sheet. Now, apart from classification of the caries, we do caries risk assessment. Now, caries risk assessment does not only involve caries activity test, it also involves the probability of persons developing new carious lesions during a specific period and whether there is going to be a change in the size of the cavity or activity of the existing lesions. Now, once you see a patient who has caries, then you can use this caries risk assessment chair site to assess the possibility of future lesions development and reversal. Uh, there are now, if you're asked as a short note, you can just classify them into physical, behavioral, socio-environmental, and treatment related. To elaborate more on this, the physical risk factors include the physiology of the enamel. If there are deep pit and fissures, anatomically susceptible areas, then you can think of giving pit and fissure sealants. If there is a high mutant streptococci count, you can go for diet counseling, and you can even think of giving fluoride varnishes. The behavioral risk factors are, especially in case of children, if there is a feeding bottle used at night, if the patient has the habit of frequent snacking, especially with sticky and sweet foods, and if there is inadequate oral hygiene, along with self-induced vomiting, such as bulimia. The socio-environmental factors may include inadequate fluoride, poor family oral health, and high parental levels of mutans streptococci, which can be solved through counseling and fluoride application. And treatment related are whether we are able to, in high caries risk patients, we are able to give a good special carbohydrate diet. If there is any medication that the patient is taking, the patient has undergone any radiation, presence of orthodontic appliances, all these treatment modalities may actually alter the oral hygiene and the oral microflora. So these also need to be addressed through special oral hygiene management sessions using specialized toothbrushes and fluoride mouth rinses. Now, this was caries risk assessment. Now we come to remineralization of incipient lesions. So first, if you are able to detect the incipient lesions, then you have to use certain methods to prevent further progress of these lesions and remineralize these lesions. So the critical pH of the saliva is 5.5, at which the remineralization and demineralization are at balance. To favor the balance towards remineralization in incipient lesions, we have to do these things, that is decreasing frequency of intake of refined carbohydrates. Patient has to follow optimum plaque control methods. We have to ensure that there is a good salivary flow. In case it is not there, we may give salivary stimulants. And most importantly, all this prevention has to be done by the patient. We are only helping. So motivate and educate the patient. we can use certain chemical agents which will decrease the demineralization and arrest the existing lesions, primarily fluorides, which can arrest the existing lesions and also help in remineralization of the lesions. So first we come to agents for arresting caries progression. The first one is silver diamine fluoride, which can be used mainly for pediatric patients. So 38% of silver diamine fluoride is used, and it is known to inhibit carious lesion progression. Then there is ozone gas, and it is considered to have a sterilizing effect, and it will kill the cariogenic bacteria. It requires an application period from 20 to 120 seconds per tooth surface to arrest caries. There is a method which is becoming popular now, which is resin infiltration method. This can be used both in smooth surface caries and proximal non-cavitated lesions. So this is used when there is incipient remineralization or white spot lesions. What happens is you give, first you will etch the tooth with hydrochloric acid, and then after rinsing and drying, you will use a low viscosity resin material, which is known as the infiltrant, uh, and then this will penetrate into these microporosities which have been created with this hydrochloric acid and fill up all these pores. And then when you are curing it, it will create an impenetrable barrier. So this does not require any cavity preparation. Now, when you come to remineralizing agents, you have clohexidine. It reduces the number of cariogenic bacteria. Fluoride enhances the uptake of calcium and phosphate ions and can form fluorapatite. And this is the best method which can be used because fluorapatite will have a critical pH lesser than that of hydroxyapatite, which is 4.5. So the tooth becomes more resistant to demineralization than hydroxyapatite. This therefore favors remineralization towards when the pH is higher than 4.5. Another popular and very effective method for ensuring remineralization is the use of CPP-ACP, which is casein phosphopeptide amorphous calcium phosphate. It is a useful karyostatic agent as it contains calcium and phosphate in bioavailable form. It reduces the caries risk in high caries risk patients and also in gastric reflux patients. And when you have white spot lesions in smooth surface area caries, there it has been found to have very effective remineralization potential, and it is also used in orthodontic patient to prevent orthodontic decalcification. It is also an effective desensitizing agent. So again, this question can be asked as a short note for which you can write these answers. Then you have other remineralizing agents such as tricalcium phosphate, which again, just like CPP-ACP, increases calcium and phosphate concentration in plaque and saliva, thus increasing the pH and decreasing demineralization. Bioactive glass available as Novamine is when exposed to the aqueous medium in the oral cavity, provides calcium and phosphate ions that form hydroxyl carbonate apatite with time. So if there are any small surface defects, non-cavitated lesion or porous enamel in white spot lesions, it stops the further erosion, further demineralization, and allows for remineralization of these defects. Other remineralizing agents are enamelon. Again, it contains calcium and phosphate salts along with sodium fluoride. It has been supplied as a toothpaste and has been found to reduce white spot lesions. Another phosphate and calcium supplying agent is dicalcium phosphate dihydrate and ion exchange resins, which are incorporated into toothpaste and again supply calcium, fluoride, phosphate, and zinc ions to enable remineralization. Now, we have discussed about remineralizing agents. Now, we are coming to the next step, that is restoration techniques of cavitated lesions. So first, we tried to assess the caries risk. Then, if we had some demineralized enamel or incipient lesions which could be remineralized, we had discussed about those. Now we come to restoration techniques of cavitated lesions. So a minimal intervention concept involves as small a restorative preparation as possible. So here, why the preparation is necessary? Because in case of a cavitated lesion, even if you arrest the caries, it is not possible to maintain plaque control in this region. So you have to restore it. First, prepare a cavity with the surgical approach and restore it. So one of the methods is preparation with hand instruments, then high-speed instruments, air aberration, chemomechanical caries removal, laser cavity preparation, and sonic oscillating systems. Atraumatic restorative treatment is one which uses hand instrument. This is introduced by Frecken in 2012. What you do is you're using only hand instruments in areas where the facilities for dental care are not good enough. You are actually breaking off the undermined enamel, and the soft dentin is excavated using spoon excavator, and then you use glass ionomer cement to restore the cavity and to any confluent pits and fissures also. And you finish the restoration with sharp carvers. Now, the advantages of ART are that you don't require any sophisticated dental equipment. There is minimal discomfort to the patient, and there is minimal training required from the operator. Now, glass ionomer cement releases fluoride, which is a karyostatic agent. So the cost is low, and you can follow it up. If the treatment fails, then you can use a more radical approach. But ART has a main disadvantage that these restorations are not long lasting because glass ionomer cement does not have good wear resistance and it has a low strength. So the average lifespan of these restorations is 2 years. And for a dentist also, or the operator, continuous use of hand instruments may result in hand fatigue. Now we come to next, that is preventive resin restoration. It is indicated in teeth with minimal tooth and fissure decay. If there is decay is limited to enamel, in that case, you are either etching, rinsing, and drying and restoring with a composite restoration or a GIC or a pit and fissure sealant. You can also use a fissurotomy bulb. So, based on the extent and depth of the carious lesion, it can be either a suspicious pit and fissure, where you are limiting yourself only to enamel. This is classified as type A. And if the lesion is incipient in dentin, it is type B. And type C is more extensive. So preventive resin restoration is confined to primarily type A, and rarely it will go to type B, but never to type C. Hall technique is a method used in primary dentition. It is a preformed metallic crown used to seal decay by cementation over carious primary molars. And here in this case, you are not doing any tooth preparation or caries excavation. You're just sealing the caries inside. Now, one important short note in minimal intervention minimal intervention restoration methods are tunnel preparation and box preparation. So tunnel preparation is actually a preparation to access proximal caries lesion from occlusal surface. In this case, the marginal ridge is preserved. So you are actually preparing a tunnel beneath the marginal ridge without undermining it. So when you are not undermining it, you need at least the lesion to be more than 2.5 millimeter below the crest of the marginal ridge, usually beneath the contact area. And you have to make sure that the access through the occlusal surface should be limited to achieve visibility and should be undertaken from an area that is not under direct occlusal load. The material of choice here is a resin modified glass ionomer cement, and because it has fluoride release along with good strength and abrasion resistance. How do you prepare the tunnel preparation? You use a small round burr, which is number 2, and it is pierced through the proximal pit, the mesial pit or the distal pit, directing the burr 45 degrees towards the proximal contact area. Make sure you have taken a radiograph before so you know where actually your caries lesion is. Once lesion is approached, you can slightly widen the axis using a tapered fissure burr, and then caries lesion is excavated, and till the completion of the cavity and the restoration, the matrix band is maintained stable so as not to injure the adjacent tooth and the underlying gingiva. So remember, you have to keep the matrix band and retainer in place at all times, starting from the preparation to restoration of the cavity. The advantages of the tunnel preparation is you are preserving tooth structure by preserving the marginal ridge and proximal contact. You are not damaging the adjacent tooth iatrogenically. There is no effect on the gingival tissue. It is cost effective and risk of overhang is minimal. But there is one disadvantage. Your accessibility is limited. Therefore, you can use it only in small lesions. You have to make sure that there is complete removal of caries because there is a risk of incomplete removal of caries in this case. Marginal ridge, the distance between the lesion and the marginal ridge should be 2.5. Otherwise, there is a chance that marginal ridge may break, and you have to make sure the direction of the burr is correct. Otherwise, there is risk of pulpal involvement. The difficulty in insertion and finishing of the restorative material should be managed by using proper condensation method and make sure that the restoration, the distance between the pit and the restoration is not very big. Now we come to mini box or slot preparation. This is actually just the proximal box preparation. You are removing the marginal ridge, but you are not including the occlusal pits and fissures. Because you are using an adhesive restoration and which is supposed to retain by itself because this cavity is a small cavity. So these cavities can be either box shaped or saucer shaped and may be restored with a resin based composite or amalgam. We come to another cavity preparation method, which is air abrasion. This relies entirely on adhesive restorative materials because there is no macro retentive features which are introduced here. So it uses kinetic energy. So air abrasion is also known as kinetic cavity preparation. You're using a stream of abrasive particles thrown at the tooth surface at a certain velocity, and it removes a small chip of the tooth structure when it hits the tooth. So you are using aluminum oxide with an average particle size of 25 to 30 micrometer. Bioactive glass can also be used in these cases. The pressure which you use with which the air abrasion will push the alumina particles outside is between 60 to 120 psi. It's a non-rotary method of cutting hard tissue, and it is an effective alternative to your air rotor. Now it is creating saucer-shaped cavity. There is no vibration such as introduced from your air rotor or your micromotor. It is relatively pain-free and has better cooperation from the patient. The disadvantage is the dentist does not have a tactile sense. There is a tendency to over-prepare cavities, and you should always use it under rubber dam isolation because there is a chance of inhalation of particles. And I said earlier, air abrasion cavities are restored with adhesive restorative material. Now we come to chemomechanical caries removal. This can be used separately or as an adjunct to hand instrumentation removal. But chemomechanical caries removal can be used in deeper cavities when you are going for indirect or direct pulp capping also. It was developed initially by Goldman, and you are using a chemical which attaches to denatured collagen, and this softens the demineralized dentin, and then once the softened dentin is sufficiently emulsified by the chemical agent, you can use hand instruments such as spoon excavator to remove the caries. The chemicals earlier were used as in the liquid form, but we are preferring gel form now. The materials used, some of the materials which can be used are Caridex, which consists of preheated N-monochloro-DL to aminobutyric acid. Caries solve is very popular now. It consists of two syringes which are mixed, consisting of amino acids in one and 0.5% sodium hypochlorite in another. Another popular and more economical method is use of enzymes, which will again soften the denatured collagen. The papain gel is very popular now. The advantage is it's painless and it is easier to remove the denatured collagen, the infected dentin, because it is softened further by these chemicals. It results in a conservative cavity preparation, and patient acceptance is also very good. But this takes a longer time, as you have to wait for the chemical to take action, and then you have to use hand instrument to excavate all this. And this also is not a completion of the cavity preparation. You may need to refine the cavity with rotary instruments. Now coming to laser cavity preparation, we have used ER-REAG and ND-YAG lasers, uh, and carbon dioxide lasers will facilitate sealing of the fissures. So in this case, laser has a dual function. It prepares the cavity and also reduces the number of carious bacteria. This acts by function of volatilizing the water in the caries. The cavity cutting by lasers are clean with minimal debris and smear layer. And again, in this case, you don't prepare very deep cavities with lasers. And this method relies entirely on adhesive material for restoration. The advantage is it is safe and efficient. There is no vibration, no noise. There is no need for anesthesia also. And the disadvantage is the cost factor, and there is a learning curve for uh, getting trained with this method. We come to the final method for minimal cavity preparation, which is sonic oscillating system. In this, there is an oscillating handpiece with a partially diamond coated working tip. It can be a safe-sided diamond coating tip so that the proximal surface of the adjacent tooth is not damaged. And these are used in small cavity preparation because these will prepare these are small tips, and if you use it for larger cavities, it will take a longer time. So you can use it for small cavity preparations, and it also ensures better finishing of proximal bevels. So here if you see the restoration techniques for cavitated lesion, the mechanism of rotary, you can use small burrs and diamond points. If you're using non-rotary methods, you have hand instrumentation, air abrasion, ultrasonics and sono abrasion. You're looking for chemico-mechanical method. It can be Caridex, Carisol, and pepsin or papain based solutions or gels. You looking for photoablation. There are lasers, and you want to disinfect the cavity and arrest the caries. You have photoactive disinfection and ozone. So if you're answering based on restoration techniques, you can use this table. Now we come to what are the restorative materials used for restoration in minimal intervention dentistry. These are GIC, composite along with dentin bonding agents, resin-based glass ionomer cement and bonded amalgam. But the most favorable materials which we use are composites and resin-based glass ionomer cements. So when we are using this material, there is another concept in minimal intervention dentistry, which is repair rather than replace concept. So if you have any previously restored teeth which require replacement of the restoration because either the restoration is fractured or there is development of secondary caries, in this case, only that area which is affected is removed and not the entire restoration. Because of this, what happens when you're trying to replace an entire composite restoration, there is a chance that you may overcut the cavity. So if the remaining restoration seems to be intact, what you do is you remove only that portion of the restoration which is chipped off or which seems to have developed caries and then restore that region. Because the previous restoration was a composite restoration, then it will adhere to the newer restoration also. And when you're trying to repair a GIC restoration, it is indicated preferably only in cervical areas. This is an advantage of fluoride release. Apart from that, in occlusal areas, composite restorations are preferred over GIC because of greater strength and abrasion resistance. So to conclude, minimal intervention dentistry is a more conservative approach to caries treatment. It involves early diagnosis and prevention. Disease should be treated first, and then if you are going for treatment, surgical approach should be taken as the last resort, and you preserve maximum amount of tooth structure using minimally invasive methods of cavity preparation. So these are some of the references you can use. Thank you so much. I hope